Any questions about the class before we get started? Okay. So great, welcome, and thanks for coming. Really very overwhelming that all of you would spend your time with us for this new class and hear about my experiences with lung cancer ongoing. I was just saying a little bit earlier that I always get a little anxious before chemotherapy. I'm still getting chemotherapy every 3 weeks. So tomorrow's my next chemo cycle. So I don't generally like that week after I get chemo because I feel nauseous for the week and a little tired. It's gotten better since I am on a maintenance regimen now. But just to share with you that experience of kind of having be this, it's long enough between sessions that I almost feel normal, and then I have to get the chemo again. So that's another part of the experience. I didn't realize how powerful that would be where I almost forget about it. Like today I need to get my blood test done, but I've forgotten to do that so far, so I need to go get my blood test done in preparation to get chemotherapy. But the topic of today is being mortal, and we're really joined by an excellent colleague for many years, Dr. Peter Pompei. Was the former head of senior care geriatrics that we call geriatrics at Stanford. I think you actually were the founding head of senior care or geriatrics? The first one at Stanford. At Stanford, right. So I still remember my introduction to Peter. I took over, I think he was covering in our teaching clinic, and I took over for him, and everybody told me, all the residents said, "Where's Dr. Pompei?" They didn't care about me, but they were wondering. So that gives you a sense of what a fantastic doctor he is and a great person to introduce the topic of the day, which is having difficult conversations with patients, but also reflections on mortality to go with this session of being mortal. So, as you heard from last week, I was in sort of this ongoing conversation with my doctor about potentially having something that is life-threatening and incurable at stage 4, which is stage 4 lung cancer is considered incurable. And so that was kind of an ongoing process. So I wouldn't say there was a distinct point at which he had a difficult conversation with me. And being a physician, I knew what was going on. But it was challenging, and people do ask me about my family members. Did I have difficult conversations with them? My wonderful wife, who you'll meet in the caregiving session, I really made sure she was updated about what's going on. I actually asked her to cancel her business trip to Japan because I knew something serious probably was happening. And my kids are 13 and 17, and they, we really wanted to, because of their age, keep them updated to really make sure they knew what was going on as we went through it. So, I wouldn't say we had any very distinct sessions of difficult conversations, but in the story I provided last week about the letter I received from the patient who basically was end of life, having decided to withdraw dialysis, that was a very difficult conversation to have, right? And that was, again, an ongoing series of conversations with him and his family. So as a physician, you definitely have to do this. And I think as a patient, maybe a little easier or harder. I think we have a guest today who mentioned that sometimes she thought as a physician, maybe we have a tougher time because we know too much, right? Maybe we know too much about the disease, and that can be the case as well. But I wanted to share with you a couple of clips from movies that I saw one of the movies before I was diagnosed, and then I saw the other movie recently, and they're basically the same. They're the same movie. So it's the movie is called Ikiru, and so that is an Akira Kurosawa movie. Anybody familiar with Akira Kurosawa? So a famous Japanese director, and this movie I'd not heard of. Is also apparently very well known. It's called Ikiru, and so there we go. And so the story goes, before the clip I'm going to show you, and by the way, I never thought I would show an Akira Kurosawa movie clip in a medical school class, so maybe we're having a record here. You can tell people the best part of the class is we got to see Akira Kurosawa. He is a public servant, so he's a civil servant, works in some sort of public works, and he goes to work every day and not feeling well and is going back to see his doctor about the results. So here we go. Let me see if my sound is on. And so he's about to have a conversation with his doctor. Okay. Hopefully this works. Uh-oh. Maybe not. Huh. It's very strange. It's very strange. Let me try this again. Could be a resolution issue. Huh. Anybody good at troubleshooting this? We can hear it, we can see the thing, and we just don't see the video. Oh, I'm sharing my screen. Oh, it doesn't, because they don't want people to play their movies to share. Oh, that sucks. Okay. Well, that just ruined my idea for today. Okay, so the way, geez, that's terrible. I guess they don't want people to show movies and make money off the movies. But so what happens in this clip is he goes, he sees the doctor, and before he sees the doctor, he's in the waiting room, and he says that the gentleman who he talks to in the waiting room says, well, this guy who just left to see the doctor, well, he actually has stomach cancer. But you know, when you see the doctor, and if he says you have an ulcer, you don't have cancer, you could just eat this limited food and you'll be okay, I wouldn't like that, because you probably have cancer, and he's just telling you that to make you feel better. And of course, when he goes to see the doctor says, you're okay, you have an ulcer. Of course, he drops everything, because now he's heard what the person he was in the waiting room was talking about. And you know, of course, now he knows he has cancer. So after he leaves, it was much better, worse with me telling it, but if you guys have Macs, you can look at Ikiru and watch for yourself. So he goes and after he leaves, the senior doctor talks to the junior doctor and says, you know, hey, how long do you think he has to live? And he says, well, maybe 6 months at the outside. And the whole movie talks about how he spends his last 6 months of life. So I think about that every day, honestly, because I know I have a limited time left. And definitely watching that movie struck a chord with me, because that's something I actively think about every day, how I should be spending my life, what I should be doing when I have a limited time, what I should say yes to and what I should say no to. So, you know, I haven't really changed much in my life, which is good. So maybe I'm living my life the way I should. But it's definitely something that crosses my mind every day. The next clip I was going to show you, and it probably is not going to work since it sounds like you can't ever share these things, is a clip from an updated version of that movie. So Bill Nighy starred, and it was a very British version of that clip. But in this case, it was an ongoing conversation. He goes, sees his doctor, and the doctor basically says, what we feared is true. So, and they don't even mention the word cancer. It's very British in that way, very kind of stiff upper lip. And he says, okay, I understand. And then he basically leaves the doctor's office at that point. It's a very short clip. This clip was much longer. So very different ways to handle that difficult conversation at different ends of the spectrum. One is kind of, you know, avoid the topic, you know, don't tell them the truth, which can be very Asian. I don't know if you guys have seen that movie where the grandmother, forgetting the name, The Farewell, they don't tell the grandmother the diagnosis, and the grandmother honestly seems quite happy with that, which is a very Asian approach to things. And in this case, it's sort of, they have an ongoing conversation. He was expecting it, and he was kind of minimalist at the end, the interaction between him and his physician. So yeah, I wanted to share that as examples. Unfortunately, I couldn't share it but I'll figure out how to get you guys the clips to watch yourself. But without further ado, I want to welcome Dr. Peter Pompei up to talk about difficult conversations and being mortal. Yeah. Or if you want one with a back, they...
No, I think I'm good. Hello, everybody. I'd like to start by just expressing my thanks and gratitude to Dr. Lin for having this course. If not unique, it's definitely uncommon, I would say. And from my perspective, when I heard he was doing this, I thought, this man is so brave and so generous to be able to share this with important people like you who will need to know these kinds of things as you progress through your careers. So thank you, Bryant. We're really grateful for your contributions here. So what I'm going to spend a little time on before we have an open discussion about these kinds of things is a resource that's available to all of you. And I've got the resource information here that you can send around, or we can put it on the board, whatever works better for everybody. But it's a variant of something that was developed not at Stanford, but at Harvard. And rumor has, I think this is true, it may be apocryphal, so somebody can fact check me on this one. But I think Atul Gawande was largely involved in developing this tool. And it's very widely used, especially widely used in our oncology division. Tyler Johnson, one of my colleagues and our colleagues who's in the oncology division here, has been teaching this to medical students and residents and fellows and all the rest. And so it's widely used, and it's a way to help us, because as you were saying, these are not easy for us to do. These are difficult conversations, not only for the patients, but also for those of us who are engaging in these difficult conversations. So it provides a template, and I've always resisted templates in my life as a physician, but sometimes they're useful. And this one in particular gives you options for language that you can use that makes it seem genuine for you to put things in your own words and be able to express things in the way that is most comfortable for you, which is what is very helpful at putting the patient at ease as well. Before I get into the details about this, I would just like to reflect on one of the things that Dr. Lin was talking about, and that is that I want to acknowledge that there are cultural differences between these kinds of conversations and discussions. And I don't want to presume that what I'm going to be showing you is the right way or the only way. It's a way that seems to work well in America and Western medicine. It may not be very suitable for individuals from other cultures. And I think we need to be sensitive to that. And luckily, built into this tool is some methods for you to be reminded that you need to be sensitive to those kinds of issues. I know, I've heard anyway, that in some cultures, bringing up these topics or discussing these serious conditions is basically a way of conjuring them up. That by talking about them, you bring them to life and make them happen, sort of magical thinking. But it may be real for people, and obviously that's the last thing we want to do is stress people out more than these things already do stress them out. All right, any questions or comments about that? Anybody want to rebut what I just said and say, I don't know what I'm talking about? Or... All right, feel free to raise your hand, interrupt, ask questions as we go through. I'm happy to respond to what your needs are. Yes?
Cultural differences come up in your practice?
Yeah, I mean, it comes up all the time. And one of the most wonderful things about the Bay Area is how culturally diverse it is. I mean, I've lived in New York City and Chicago, and I find the Bay Area more culturally diverse than other places that I've been. And I mean, I can give you plenty of examples, but It's my habit to, for instance, I'll give you one brief example. It's my habit when I begin the physical examination is to ask to see the patient's hands. So I extend my hands and ask them to extend their hands. And so the first touch is hand to hand. Well, in Western society, that's perfectly fine. But in other parts of the world, touch may be not very comfortable for people. They may not want to be touched, especially if there's a gender difference or anything else. So that's one example, but there are many examples of how we encounter people whose culture we may or may not be very familiar with, and who we recognize, though, we might need to address them and treat them slightly differently than what we would somebody that we know well. Yes?
How do you deal with like a lot of the ethical considerations with cultural differences if patients don't want to hear certain information, but then also you're giving us like a physician to give them proper
Yeah, that's a very, very difficult situation. And often, my strategy often is to involve the family to some extent and see if I can find a way to build consensus about what information can and should be shared, and share with them my discomfort about not being open and honest with the patient about this. But I think it would be hard to go against a patient's wishes. I mean, we recognize that people can decline our treatments all the time, right? So they could also decline, what we want, what we'd like to tell them. But it is painful, and I think that's how it's identified as an ethical issue. It makes us feel uncomfortable to some extent. All right, so when engaging in these kinds of conversations, it's first important to have a comfortable environment, a learning climate, so to speak, if we were using Kelly Skiff's paradigm. And meaning that we have to have enough time, and we have to be sure that we're not looking rushed and our hands not on the door, ready to get out the door. We have to set aside some time, and then we have to ask permission to engage in this conversation. So setting it up first, the first thing we would do is say something like, I'd really like to talk to you about your medical condition, and there's some serious things that I think we need to address together to optimize your care. Would that be all right with you? So you give them the option of saying, hell no, I'm not going to listen to this. I don't want to hear this. I want to go home, whatever. Or they might say, yeah, this is a good time. I think we probably should do this. Or let's set aside another time when I can bring my family, or whatever they want to do. But it's important to be respectful of the patient and their wishes and that sort of thing. So setting it up that way is going to be a first step that you want to do. And then something that's always very important is to be a good listener first. So after you've gotten permission and you set it up and everybody's cool and relaxed, and as cool as you can be, I guess, in these situations, it's important to ask, what is it that you understand about your condition? And I think it'll help us as we go through this to give you a specific example. I'm not an oncologist, so I would feel very uncomfortable talking about Dr. Lin's situation or other cancer situations, largely because I'm not familiar with all the various options and treatments and nuances and that sort of thing. And so knowing your song well before you start singing is important. You don't want to go in there and just wing it. You need to have some understanding and be able to be confident in your understanding so that you can be honest and open with the patient. So let me take an example of a case that I had to deal with, which was a man who had advanced congestive heart failure. And he'd been in and out of the hospital for a while. And he eventually told me, look, I don't really want to do this anymore. I don't want to keep getting hospitalized and getting poked and prodded and being threatened with ventilation and ICUs and that sort of thing. I'd like to just stop my medications and see what happens. So if we had a patient like that, I would first ask him, so what is it that you understand about your illness, and what do what do you see happening with your illness, and try to get a sense of what it is that he understands. Now, we're fortunate with Dr. Lin, obviously, but also I was fortunate with this man to have someone who was, intelligent and educated and knowledgeable about some medical issues. And so he didn't have any kind of wild ideas or unrealistic ideas about what might happen or how things might go. If you're faced with that, it's important to know that, though, right? I mean, if somebody has clearly a very different view of what's likely to happen with them, it's important for you to know that. And then you have to realize that what you're saying may not be very acceptable to them. That doesn't prevent you from saying it, but you have to recognize that it may not be heard in the same way it might be for somebody else. All right, so you've set the stage, you've asked the person for permission, you've gotten their sense of what it is that's going on, and then it's our responsibility as physicians to talk to them about our understanding. So I would say, I'm hopeful that you'll have many good days. And it's also true that heart failure is a very serious condition, and it's very likely that you'll have sudden deterioration from your heart failure, or you might have a different problem arise that could seriously complicate your present condition and cause you to become very ill very quickly. And so it's going to be helpful for us to talk about what you would like for us to do in those kinds of situations. Okay? So you try to be as honest as you can about what is going on and that sort of thing. And then this is the hardest part, for me anyway, is to talk about time. Because there's a lot of uncertainty about that. And so what helps me is to acknowledge at the beginning that none of us know for sure. It's uncertain how long things are going to be, you're going to be able to go on and continue. But I fear that your days may be short and that you may only have weeks to months to live. And then you sort of have to stop and let that sink in and try to get a sense of whether that's a shock for them or if it's something that they also anticipated and understood, and whether they want to say, oh, that's ridiculous, doctor. I'm going to live for another 5 years. I have to live another 5 years. My granddaughter's going to graduate and, whatever. So you often have to allow that time and space for people to react to whatever it is that you've said about the timing. And then you can talk to them a little bit more about the next steps and what, how things might go from your perspective and what you're hoping for, but what you're also recognizing may not be the case for them, okay? The next general category that you do after you sort of given that information to them and allowed them to respond to it is to find out from them, again, listening carefully for what's important for them. So, and this is what Dr. Lin already commented briefly about, and you can put it very explicitly. You can say, so what are your goals for the next 6 months? Which sounds threatening. And if somebody asked me that, I might have a hard time answering that. So you could try to do it more gently and say, what do you hope for? What do you hope to accomplish in the next short while, for instance? And try to get a sense of what's important for them. What is it that they want to do? So if it's important that they attend their granddaughter's graduation in 5 years, you might have to respond by, wouldn't it be nice if that could happen? It seems unlikely that you're going to be here 5 years from now. And so what can we do before that that would make up to some extent or address the desire that you have for attending this graduation? So you ask them, sort of try to get a lay of the land of what they'd like to accomplish. And then you ask them for their fears. What is it that you fear most about the time that you have left? So that you have a good understanding of what it is that they would not want to have happen. So you'll learn more about this as you go through your medical careers, but there are certain devices and certain interventions and treatments that I can tell you right now, I don't want. So and I tell people that, I don't want that. Don't do that to me if it comes to that. I'd rather just not have that done. So addressing their hopes and fears, or their fears and concerns is very important, and try to get us so that you understand where things are going. And then you ask them about their strengths. What is it that really allows you to do things? I mean, what is it that builds you up, that makes you feel good about yourself and your life and your family, et cetera, et cetera? And how can we strengthen those? How can we strengthen those kinds of things in your life that are going to be important for you in the short term? And then you can also ask them about what are the functions that you really would have a hard time giving up. So, for instance, it would be very hard to not be able to get in and out of the bed on my own, they might say. I mean, I feel or to use the restroom on my own. So some people would say, look, I really don't want somebody else having to help me get to and from the bathroom and in and out of the shower. So just get a sense of what it is that is important for them and what they would really rather do without. Some might say, I don't want a bladder catheter, for instance, or a feeding tube, for instance, put in me under any circumstances, so that you know what it is that they're hoping for and what they want and what they don't want. And so you explore as best you can all the concerns, the hopes, the strengths, the expectations that the patient has. And then in the end, it's important, the last part is to finish with a concluding statement, a statement from you as the expert physician here who they've come to for advice and counsel. So you don't finish this and say, well, I wish you well, good luck, see ya. It's important for you to tell them, from what you've said, I understand that these things are important for you, that we'll do everything we can to preserve your abilities to get in and out of the bed, to avoid the need for any kind of catheters or tubes, and that we will involve your family with decisions if that was part of the discussion, that's what they wanted, what their support system might be. And we'll work together to provide you the best possible care we can. So that's kind of the overall gist of how things go. It sounds like what Dr. Lin has told us is that he's had these informally conversations with family members, right? I mean, he may not have had a sit-down conversation with his oncologist to really clarify all these things, or his primary care physician. But they can be done in other situations, I mean, with family members and friends and that sort of thing. But as healthcare providers and those that are going to be responsible for helping make decisions about what's being done, it's important for us to know those kinds of things and to have a difficult conversation with a patient who's facing serious illness of some kind. And this doesn't, I mean, these principles apply to a variety of different things. It doesn't have to be only end of life or serious illness kind of situations. These discussions come up with me very frequently in my role as a geriatrician with taking people's car keys away from them, right? I mean, that's a tough conversation to have. I mean, people don't want to do it. You're not the DMV. You can't, I mean, if they have a license, what are you going to say? But you can at least engage in the conversation, help them understand what their strengths are, what alternatives to driving the car might be, and then coming to some mutual agreement about the safety issues involved with not driving when they have problems with that. So it's wide-ranging. It doesn't have to apply just to one particular area. But I think if you think about the principles and engage patients and be a thoughtful listener and careful about what it is that you tell them without avoiding the truth and being honest with them and leaving them with your best recommendation based on their hopes and dreams, so to speak, and the reality of the situation that they're in. and not doing that is really abrogating our responsibilities as professionals. So I would encourage you to really think hard about learning these skills so that you can provide effective counsel to your patients. All right, I'll stop there and hear more rebuttals or questions or comments.
I had a comment just made me think of something was, and also talking to our colleague, Dr. Kelly Skeff, who is writing a book about interviewing the patient. I mean, should this type of conversation be the first conversation? Because a lot of what you're, saying is like just getting to know the patient, right? I think, I think to me at this point, especially, I think about, geez, I should know what the hopes are, not just for that meeting, what their hopes are for the meeting, but what my patient's hopes are broadly for every patient, that's new to me, so I can know what they want to do, what they want to get out of life. I mean, maybe it's not so easy to answer, but yeah, I like that framework of hopes and fears. What are your hopes and fears as opposed to goals per se? So yeah, what are your thoughts on, geez, we should have this conversation with every patient and maybe at the very beginning?
Yeah, I totally agree with that. And I'm criticized and sort of known throughout the medical center for overemphasizing the social history. So, and I plead guilty to that. I find it engaging and fascinating and invigorating, and so I love doing it, and I'm not going to stop. But a lot of the residents say, what the hell are you talking to them about that for? So anyway, I'm thinking now, too, that there's a new project that's being led by some of your folks, your colleagues in SIM, on getting the full patient story, giving residents the opportunity to spend an hour or more with the intent of providing medical care for them, but just getting to know them as people. Who are you? What's important to you? What's your life like? What's your trajectory been, et cetera, et cetera. And then having that as part of the medical record so that everybody would have access to I don't know what I would call it, life history, or I don't know what I would call it, but something that gave more details about what was important to folks, because in a busy clinic, we often don't have time for those kinds of things. We're so busy trying to figure out how best to help them and what to do in a relatively short amount of time that we don't have a chance to explore that in great detail. And so I agree with you that it should be done as we get to know our patients. And the good news of people who provide primary care is that you have the opportunity to see people over a longer period of time. And so you can accumulate that information gradually over time. But consultants often are seeing the person for the first time. And the case that I was referring to with the heart failure patient was somebody who wasn't my patient initially, was in the hospital and was being discharged to me as a nursing home doctor to assume his care now that he no longer wanted to be back in the hospital. So he was new to me at the time, and so that was my only opportunity to try to figure out what he was eager to think about and talk about. Yes?
So if you have a patient who you think does not have a chance to recover, but they're really optimistic about their outlook, would you think that it's better to be realistic about it, or would you rather keep them hopeful?
Well, that's a great question, a great way of putting it. I don't necessarily see a conflict between hope and longevity. I think you can be hopeful and optimistic even if you have short time left. So I would argue that it's important to preserve the hope and optimism for sure, because that's always a good thing in my experience. But I'd also help direct them or redirect them to thinking about remaining hopeful and optimistic in a constrained or shortened period of time compared to what they might think, what they might have thought was going to be the time frame for their existence.
I totally agree. I've said this a few times, I don't know if to the class, but if I were to really think about, when Dr. Louis, who came in the first session, says, 5-year survival rate for lung cancer is about 9%, right, for stage 4. I know that. I rationally have that in my mind, but it doesn't mean I can't be hopeful. It doesn't mean I can't be optimistic. So it is a balance, and it's a tough balance in that, you also like as a physician, you're judging somebody or maybe assessing them. Are they really understanding what you're telling them, or are they just taking the part that they want to hear, right? And that's very tricky. But yeah, I think you can have both. It's not necessarily one or the other. You can have optimism, but still understand, the facts as we know them. I think that, to me, that's the case. I don't know, Peter, what you.
No, I think that's right. I mean, it's not, it may be hard for us to imagine that kind of thing, but we all recognize that we're going to die at some point, and sooner or later depends on a lot of factors that we don't have control over. But we can try to stay optimistic. Sir.
Yeah, I wanted to ask about information and informed hope versus uninformed hope, and the difference in how you judge that and try to work with it in these conversations. Because obviously Dr. Lin is a physician, he's able to look up the cancer statistics to see that there's a 9% survival rate. And so.
Yeah, that's a great question, and it gets back to my knowing your song well before you start singing, because you really need to know that. And if you don't know it, you need to find out. So there's statistics and there's data about life expectancy in somebody with stage 4 heart failure, for instance, treated. And then if it's untreated, you can expect that it's going to be less than that. Another example where this difficult conversation comes up frequently in my practice is around dementia. So when I talk to a person with early onset dementia, and I'm talking to them, having this difficult conversation with them, what I can share with them is that the statistics show that the average life expectancy from the time of diagnosis till death for Alzheimer's type dementia is about a decade. I mean, it's quite variable, right? But about a decade. And so acknowledging the variability, but saying that the average might be, or the mean might be a decade, that puts things into perspective for them. So, and I think it is important to give these things numbers, because what is a good when you see a good prognosis or a good that can mean a lot of different things to a lot of different people.
So I think you need to understand how the patient wants to engage. So some patients do want to engage in a very high level, lots of information. They want to become the expert in their disease or problem. And then some patients don't want to engage. They don't necessarily want to know all these details. We were talking about this earlier at lunch. And, you just have to understand that, maybe some people do make that choice where they are delegating some of their, the thinking around their medical care to other people. Or they don't want to engage in that way because maybe it will cause them distress or something else. So I think understanding how people want to engage, like I could have engaged, especially as a physician, to be like, I want to become the expert in lung cancer. And I am by no means an expert. I think I read a few more studies since I was diagnosed, but I didn't go and take this deep dive and really think about, going to other places and what do I do next? So I was comfortable with delegating that to my oncology team. So, everybody wants to engage in different ways, and part of that is making sure you understand as a physician or a caregiver, a friend or family, how they want to engage and what's that happy medium for them. I mean, there's not a right answer to that.
And just to highlight that, and thank you for your comment, that was another one of the bullet points in this guide that I failed to mention. So before you ask them for their understanding of it, after you are working with them, you ask, how much information do you want me to tell you about? What is it that you want to know? Because if they don't want to know a lot, then you need to know that you don't want to overload them with information. So thanks for bringing that up. That was, yes?
I had a question for Dr. Lin. So before your diagnosis, had you thought about how you would react if you had to go through this conversation with a doctor, if you indeed did get diagnosed with something, and then
You mean as a patient or as a doctor? As a patient, okay.
how would you react in that situation? And then after the diagnosis, do you think that your expectation aligned with how you actually did react, or were there differences that you noticed?
Yeah, I don't. I mean, my kids always kind of make fun of me and like, you're very morbid, Dad. And I think a lot of doctors maybe perceived that way because we're always thinking about the pure medical side. I'll give you this just a side anecdote. This is a terrible story, but I'll share it anyway. So two doors down from us, there was one of our neighbors who we really didn't know. His house was kind of crumbling, and he kind of seemed like a typical Bay Area guy. Had his surfboard there, and stuff would fall, like big branches would fall in his house, and he would never move it. And then one day we were driving home, and we saw there were all these moving cars there, like tons, like cleaning out the place, and there was all this stuff in the house. And of course, I was like, I think he may have passed away. And the kids are like, God, you're morbid. Why would you think that? Like, why would you think that? And of course, it turned out he did pass away in the house. And I've actually thought about, geez, what if it's funny. I got my long delayed colonoscopy in January before I was diagnosed, and that thought went through my mind. I was like, geez, and rather than thinking I had lung cancer, I was like, God, maybe I have stomach cancer because I got bad reflux, and Asians get more stomach cancer than other groups. And so I thought about that, and interesting, I would say my emotional reaction was much, I think it was a shorter duration in terms of the turbulent part. And I do really believe in the stages of grief now, because you really go through them, at least for me, it was very in rapid succession. Anger, bargaining, denial, acceptance, and there's one more. God, I always forget what's the one. There's like, was that? Bargaining, yeah. I didn't really bargain, but all the other ones I kind of went through fast and quick, especially at the beginning. It was sort of definitely the denial was there. So yeah, I would say I accommodated to the news much faster than I thought I would. So that's it's interesting. You never know till you go through it. I think also part of this was about how you feel. If you're feeling better, it's kind of easier to manage emotionally. So, I started to feel better fairly quickly during the course of my treatment, whereas feeling worse can be tough because you're limited in what you can do. So I think that had a lot to play into it as well. Does that answer your question? Okay.
Oftentimes, like people who are in the healthcare field maybe have more knowledge about licensing measures, and therefore often personally do not want a lot of those measures, whereas maybe someone from the general public isn't going to have as much of that knowledge. And so I was wondering how you reconcile that, if when you have patients who maybe don't have that knowledge, do you do the same process regarding licensing measures with them? Versus assessing how much information they want and potentially giving that information.
Yeah, that is very tricky, and it is true that we see a lot more than many people on the street would have appreciated in terms of options. So again, hopefully I would have a good understanding of what was realistic for a particular individual, and then describe as briefly and as succinctly and as neutrally as I can what it would mean to have a feeding tube, for instance, or to have a ostomy done, or any of the other kind of procedures that could arise. But I wouldn't talk to them necessarily about everything in too much great detail. And I often ask, and this can be very helpful, have you ever seen anybody or known anybody who's had a tube through their nose for a prolonged period of time, and how have they described that? And some people will say, there's no way in hell I want that kind of thing, so because my neighbor had it and looked miserable. So.
I'll just add, it's very difficult with some patients. Some patients, it's surprisingly easy. It's hard to predict, at least in my experience. And it is very easy, I think, I just want to reiterate what Dr. Pompei said. It is very easy to bring your own biases to the table when having the discussion. So that can be challenging, especially as physicians, and we see so often. A lot of colleagues will joke around about having like DNR tattooed on your chest, so they'll know, do not resuscitate. So the paramedics will know, hey, don't perform CPR. So that it is challenging not to bring your own personal biases regarding that belief to the table, and can be difficult. I only have a couple minutes left. I want to ask you a specific question. I know you said we're not oncologists, but we diagnose cancer, right? Most places, cancer is diagnosed before you even see the oncologist. A lot of people don't understand this. Oncologists, by and large, don't diagnose cancer, they treat cancer. So how do you have that conversation? And I've had difficulty in the past when it is true we don't know, because we don't know a lot of things when somebody has the tissue biopsy comes back, and we don't know the staging, we don't know what kind of treatment they're doing. Because we don't know the staging, we don't even have any data regarding prognosis. How do you manage that? Because you don't hold that back the data. Well, I'm not going to tell you anything until we have all this. How do you manage that situation where you have lack of information and there's this ambiguity there?
So I think it's important to recognize that these conversations are not meant to be a one and done kind of thing. So it's possible to initiate the conversation and say, I got some serious news that's not so positive about your biopsy, and it looks like you have cancer, for which I'm going to refer you to the specialist. And as soon as we have more information, we can talk in more detail about things. So I think that's kind of what I might think about doing.
And it can be challenging because they'll have
Very
many
challenging.
questions.
Very
And I
challenging.
frequently, which I think is appropriate, say, I don't know. I just
Right.
don't know. I don't have that information. I
Exactly.
can't help you with that. And that can be difficult, especially I've seen for younger doctors to say, I don't know. Yeah, it can be challenging to do.
Yeah.
Well, thank you so much for your time.
My pleasure. Thank you.
Thank you. Thank you for your kind words. And next week, I think we have Dr. Neeraj Sehgal. Is that right?
Oh, great.
Yes, talking about healthcare access. Okay, awesome.
And then I know that we talked about quite some heavy topics today, and so the TAs will be hosting some sort of office hours or kind of open debrief session if anyone wants to continue talking about this topic. So yeah, look forward to an announcement for that, and we'll see you all next week in this room.
By the way, we have a mixer tonight, right?
Yes, 5:30 in front of the CSR, where the birdcage is.
So it's a medical humanities and student mixer. Even if you're undergrad, you're welcome to come. We'll have food. And usually we have way too much food. So please join us there, 5:30 onward. And great to see you. Thanks so much.
Bye, my friend. It was great.
Hey, thanks for coming.
Thanks for doing
Really
this.
appreciate it. Yeah. Thanks for the kind words.